But to keep you in suspense, before we get there, I have a few housekeeping issues that I need to go over because we are going to be live streaming this, and this will continue to be on YouTube thereafter. So first of all, we are broadcasting live via live stream on YouTube. Please use the microphones to ask questions. There are going to be a lot of really, I think, exciting questions after we're done today. The recording is always available for viewing. Consider subscribing to our YouTube channel to get notifications when videos are added, especially because this will not be the last time we're going to be talking about really exciting topics like this one. For our viewers, if you'd like to submit a question, you can interact with us by texting DeBakey, that's D-E-B-A-K-E-Y, to 37607. I'm going to say that again. Text D-E-B-A-K-E-Y to 37607. You may also submit questions via the live stream feed. Find the video on livestream.com via this URL. We have two conferences coming up in June. Pre-intern training for vascular residents, June 5th through 7th, which I believe is already fully subscribed. And then cardiology for the non-cardiologists on June 17th. So, without further ado, at this point, I am absolutely thrilled to bring today Dr. Zach Steinberg from the University of Washington. Zach, of course, has an incredibly historied background and an incredible pedigree, having done medical school at George Washington University and then thereafter doing training at the Oregon Health Sciences University, and then thereafter has become faculty at the Adult Congenital Heart Program at University of Washington. But importantly for today, he has really pioneered some of the most amazing techniques in the advancement of balloon pulmonary angioplasty for chronic thromboembolic pulmonary hypertension. I'm absolutely thrilled to have Zach come today because, first of all, he helped us start our balloon pulmonary angioplasty program a little bit more than a year ago today, where he came to proctor us. And I would say even before that, a little more than a year prior to that, I was able to come and watch his case at University of Washington, where he did some procedures and techniques that just absolutely blew my mind. So without further ado, at this point, I would love to invite Dr. Steinberg to come up here and tell us about some of the amazing innovations he's brought to balloon pulmonary angioplasty. Zach.
Thank you all. And thank you, Huey, for the invitation. I'm honored to be here at such a storied institution that's been at the forefront of pioneering cardiovascular therapies for so long. And in that vein, it's my pleasure to spend the next hour talking with you about balloon pulmonary angioplasty for this very specific disease population. As Huey mentioned, my day job is an ACHD and ACHD interventionalist, which sometimes puts us in the lungs. But until I really dove headfirst into this disease state, I didn't really appreciate how complex the anatomy is in the lungs and this particular challenge of intervention. And it's really undergone a major evolution in the last 2 decades since it was first described. And interestingly, when it was first described, despite being effective, it was essentially abandoned by the world at large for the most part for another 10 years. And it's a really interesting story. I think it provides some lessons that we can learn from as well. So I've entitled this talk, The Uphill Battle for an Effective Therapy. Over the next hour, I'll talk a lot about the various different therapies, but if you remember nothing else, I think it's important to come away with the fact that CTEPH is a bad disease, and that stands for chronic thromboembolic pulmonary hypertension, which is a mouthful, and I'm not going to say that again today. So CTEPH is how we all refer to it. Surgery is very effective in this patient population. It's been around for a while, and it works, but many patients are inoperable. And then balloon pulmonary angioplasty, which is really targeted for those inoperable patients. It's not a therapy instead of surgery. It's a therapy for those who are inoperable. It's on the rise now. CTEPH occurs when pulmonary emboli don't fully reabsorb. And if you look at the studies for patients who present with acute PE to ERs who undergo appropriate anticoagulation, it's occurring in about 4% of patients. But that's really only a minority of the CTEPH population. As you can imagine, if you show up with a massive PE or a submassive PE, it's a clinically evident issue. patients are started on anticoagulation, and they're monitored, or they should be monitored. And these are the population where about 4% will end up not reabsorbing their clot fully. But a lot of the population are actually throwing small subclinical PEs. And when they first develop, you don't necessarily get symptoms right away, or you get subtle symptoms. And then if you throw more thrombus, you may start developing worsening exertional dyspnea akin to many other disease states where it's slowly progressive, but PE isn't necessarily on anyone's differential just yet. And that's problematic because these are patients who require long-term anticoagulation. And as the thrombotic burden builds up, people become quite debilitated and can live like this for years before they're actually diagnosed. And that's where a lot of this population comes in. So it's probably a lot more than 4% of patients who have PEs are developing this. What happens once the thrombus is in place, it undergoes a fairly rapid histologic change. These are the top panel's a trichrome stain. And you can see at day 1, when thrombus is removed, it truly is thrombus. It's aggregates of platelets and red blood cells. But even by a week, you start to see infiltration of fibroblasts and collagen, and that's designated by the blue stain here. And by a month, it's almost completely taken out by scar tissue. So though we call it chronic thromboembolic disease, it's not clot anymore at this point. And if you look at histological stains months down the road, like the bottom panels, an H&E stain, you'll see in many of these lesions, robust neorevascularization. These stay highly obstructive, but they undergo this complex remodeling, and we'll revisit that in a little bit. We don't know why this disease exists. What's the problem? It's probably not one unifying diagnosis. If it is, we haven't figured it out yet. But there's clear risk factors, and those have been outlined time and time again. A large thrombotic burden for any single PE is going to be at higher risk. Recurrent subclinical PEs, as I talked about, certainly a risk. Genetic hypercoagulable disorders, and patients with more comorbidities are at higher risk. Many of these comorbidities, such as long-term chronic cancers, which are themselves hypercoagulable disorders but acquired, are in this group. And if you had to make one generalization about who's at risk, looking at all of these, it's that people who make a lot of clot are going to retain these clots at least a percentage of the time and develop CTEPH. Among some of the issues with pulmonary hypertension in this obstructive vascular state is that the unobstructed vasculature are going to be exposed to higher and higher pressures. And so you get a cyclical phenomenon where you get this pulmonary arteriolar hypertension superimposed on the vascular obstruction, which increases PA pressures and worse pulmonary vascular remodeling, and it's a downward spiral. So even those who are on long-standing anticoagulation, but in whom obstruction is not well treated, they tend to get worse over time. This is a disease where we have some insight into natural history. This is probably the most often quoted study and the best of them from 1982. It's looking at patients between the late 1960s and throughout the 1970s when warfarin was available, but there weren't really many widespread revascularization strategies available to this patient population. And what they showed is that if patients at the time of their diagnosis presented with a mean PA pressure of less than 30, their survival over 10 years was essentially equivalent to the survival in an age-matched group at that time. But above a mean PA pressure of 30, and survival was worsened. And further supporting this, that the higher it went, the worse the survival was. And despite only being 76 patients, this was a statistically significant finding. So just to sum up, CTEPH is a problem. It's a problem when PEs aren't reabsorbed properly. And it's especially a problem when smaller PEs go undiagnosed because patients aren't receiving prophylactic anticoagulation. And it's not just a disease if left over time of obstruction, but it becomes a pulmonary vascular disease as well from remodeling. The therapy that we offer patients currently falls into these categories. Nearly everybody gets some sort of preventative strategy, and for many decades it was warfarin. Nowadays, DOACs are very commonly used and highly effective in this patient population, and for ease, that's what most patients are on, most but not all. In terms of treatment strategies to deal with the obstruction, there's pulmonary vasodilators, which of course doesn't deal with the obstruction, and I'll chat about that, and we'll run through some of the data there. There's pulmonary thromboendarterectomy, which should not be confused with pulmonary thrombectomy. Pulmonary thrombectomy, you open it up, you pull out clot. Pulmonary thromboendarterectomy is much more involved and more complicated. And then balloon pulmonary angioplasty, which I promised to go into detail about. Let's start with pulmonary thromboendarterectomy, because this has been the mainstay of therapy for a long time, and it's highly effective. What pulmonary thromboendarterectomy is, it's essentially a denuding of the inner layer of the pulmonary vasculature. It's a true endarterectomy. Here's a video showing some clips of what's involved. It's an open chest pulmonary bypass procedure in which incisions are made in the central PAs, and then a fascial plane is formed between the intima and the media around this very, very challenging fibrotic material, which is so densely adherent to the intima, you just can't remove it without taking out the inner lining of the vessel. And the idea here is to follow these fascial planes distally so that even though your access is centrally, you want to pull out this fibrotic material and block. And there's all sorts of instruments to help surgeons do this. It's been around since the 1960s, but really became popularized a few decades later, where it spread across the globe. And over the last few decades, there's been many centers who perform this as the mainstay of treatment. In one of the larger registries, 17 centers across Europe, they reported their results in the early mid-2000s, and they showed substantial hemodynamic improvements, near normalization of hemodynamics, and equally as important for this highly morbid disease was functional class improvement. 3/4 were NYHA class 3 and 4, whereas just under 90% were NYHA class 1 and 2 post-op. And the mortality, which had steadily dropped over decades, was pretty tolerable at just less than 5%. But experience matters. It matters with all technical procedures, and UCSD, which pioneered this surgery, still really is considered a leader in the field. And this is one of the reasons why. They came out with their own data spanning the same amount of time as the European registry in 500 PTE patients. They had nearly identical improvements in hemodynamics, but half the mortality. And one plausible explanation for this is they just do a lot of these procedures. Per year, over this span, all 17 centers were doing 193, and UCSD alone was doing about 125. So they're a real powerhouse. Unfortunately, there's a large proportion of CTEV patients who are inoperable, and there's different reasons for that, and they've been well described, and most studies agree and settle on around 40% of patients with CTEV are inoperable, 40%. And the reasons for inoperability, there's a few, but by far the most common is the distal location of the disease. The disease is too far out to reach for a surgeon. A substantial minority, about 1/4 of the inoperable patients, just have too many comorbidities. It's a highly comorbid group, as I mentioned. When it comes to the distal location of the disease being really the primary reason most people are inoperable, it helps to take a look at the pictures and where these diseases can manifest. We talk about them in terms of levels 1 through 4. And the higher the level you get, the more peripheral these clots start. So while the clots may extend peripherally in the earlier levels, they really start more centrally. In level 1, they start at the branch PAs. It's hard to believe that someone who had level 1 disease, shown here, survived, but they did. Level 2 disease, the disease starts at the hilum. Level 3 at the segmental level, and level 4 at the subsegmental level. And it's really level 3 and level 4 disease that most surgical programs just won't even attempt. Some have attempted. The results are not as good as if they can get a hold centrally. So these really are the patients that have been left without a good revascularization strategy for many years. It's also important to mention that not everybody has a robust hemodynamic improvement. Nearly 1 in 5 patients have residual pulmonary hypertension, meaningful pulmonary hypertension, and are left with debilitating disease. It's also the case that some people reform pulmonary hypertension because they're throwing more clot due to anticoagulation, non-adherence over decades of mandated anticoagulation. This happens. And most programs won't offer a second surgery. It's really challenging. The response to the vessels after an endarterectomy is robust inflammation. The tissue planes are altered. The risks of the procedure go up and the efficacy goes down. So there is also a proportion of patients who undergo surgery who don't get this response, redevelop the disease, and they are left with a problematic disease. Pulmonary vasodilators have been looked at in this disease. There's been a number of randomized placebo-controlled trials. They're all done on inoperable patients. They've been done with multiple different drug classes. Riociguat is a guanylate cyclase stimulator, bosentan and macitentan are endothelin receptor antagonists, and then treprostinil is a prostacyclin analog. All 3 of these classes have been studied. All 3 improve hemodynamics out to 3 months, and in some cases pretty substantial improvements. However, with the exception of riociguat, functional class and/or quality of life, it's probably more a quality of life issue, but it's unchanged. It's really kind of null results as far as patients are concerned. Why? Because these medicines have side effects, and some of them are quite debilitating. You get debilitating headaches, you can get really insidious nausea and vomiting, recalcitrant peripheral edema. There's also a hypotensive effect, and so many patients can't get up to gold doses because of systemic hypotension, and it causes worsening hypoxemia by VQ mismatch. So there's a number of reasons patients don't feel better even though their hemodynamics improve. It's also important to point out that pulmonary vasodilators may help this secondary pulmonary arteriopathy, but they're not doing anything for the obstruction. The obstruction remains, so they're not getting at the root cause of the disease. So in summary, surgical pulmonary thromboendarterectomy is very effective, but many patients are inoperable or have residual disease and then are not eligible for repeat surgery. And pulmonary vasodilators offer some but limited benefit. And this paves the way for yet an alternative therapy, and one designed at revascularization that is able to access these more peripheral vessels and is potentially lower risk for a high-risk surgical population. And that's where balloon pulmonary angioplasty comes into play. And it's pretty simple. Everyone in this room is already very familiar with this. We've been doing this in the coronaries for eons. Of course, it was largely abandoned as the primary strategy for coronaries because of a robust neointimal hyperplasia. This does not happen in the pulmonary arteries, fortunately. But the concept is the same. You pass a wire across the lesion, use that as a rail to deliver your appropriately sized balloon, you crush the disease off to the side, and you restore distal flow. And not surprisingly, this was really first attempted in the mid and late 90s when this was taking hold in the coronary arteries, and published in the early 2000s by a group out of Boston Children's. Really the first ever report on patients who underwent balloon pulmonary angioplasty. They reported on their 18 patients. These 18 patients underwent 47 procedures, and it's probably a good time to mention that that's not uncommon. In fact, patients undergo repeated interventions because it's challenging. There's so much thrombotic burden in many of these patients before they're diagnosed that they just require too much time in the lab, too much exposures, too much contrast, too much radiation, and too much time at the table to accomplish it all at once. So these are repeat procedures. So 47 procedures in these 18 patients where 107 lesions were treated. That's about 2 interventions per patient, about 6 lesions per patient. And what Feinstein's group saw was that patients felt better. This was felt subjectively with New York Heart Association class, and this was noted objectively with a 6-minute walk distance. And hemodynamics improved from the mid-40s to the mid-30s. And then they presented their complications. There was one intraprocedural complication, which was relatively well handled. It was a PA perforation that required a coil occlusion. But they saw a substantial amount of issues post-procedure, peri-procedural, within the first few hours. About 1/3 of patients required increasing supplemental oxygen and spent an extra day or 2 in the hospital undergoing some intensive diuresis for what they were seeing as pulmonary infiltrates. And they termed this at the time reperfusion injury. And for a few years, for many years, it really was thought to be a reperfusion injury. The high pressure of the flow against a relatively fragile vascular bed, which hadn't been perfused in some cases in many years, and that there was just rupture of the tiny vasculature. We really don't think that's probably the case anymore. There's been evolution in this thinking. It's probably all true vascular injury from the balloons itself, sometimes really on a level so small you can't see it in the cath lab. But whatever it is, it was causing hypoxia, and just under about 1 in 5 patients require mechanical ventilation from this, and there was 1 death. And despite the benefits of the procedure, it lost the support of the CTEPH community, and it was essentially considered to be too high risk. So to give you an understanding of what's going on and when, the timeline of things, warfarin been around since the 50s, PTE emerges in the late 60s and really becomes popularized through the 80s and 90s across the globe. BPA begins in the mid-90s, with the published results in the early 2000s, and then stops. Really, nobody's doing it after that, or nobody's doing it publicly. No one's publishing their data for some time. And then you get all the trials of the pulmonary vasodilators in the 2000s, but there's still a substantial amount of time where the technology is there, but patients don't have effective therapy. And I ask this, and I don't supply the answer here, so I hope I'm not keeping you in suspense, but why was it abandoned by the CTEPH community? It's a high inoperability of a very morbid and mortal disease, and there's no alternative therapy to PTE. At the same time, you have a new therapy that's clearly reducing mean PA pressures, and what one would hope is that that's really changing the trajectory of survival for these patients. Patients are feeling better as well. And there's a mortality, yes, there's other issues and complications, but a mortality of about 5.5%, which is fairly comparable to the surgical mortality around that time. It's held to a different standard. It's held to a different standard, and there's a lot of people who probably could benefit from this. Unfortunately, there were people in the community that really felt like this would be a worthwhile intervention to pursue, really because in a decade's worth of work, no alternative strategies have been created for these patients. And in the early 20-teens, a landmark study came out of Japan by a lab run by Hiromi Matsubara, who is now synonymous with BPA and CTEPH, really changing how the world looked at the intervention. He published a report on 68 patients that he had been performing BPAs on for the prior several years. He did 255 procedures, so more than 3 times the amount that Feinstein's group had reported on. And he knew he was up against a lot of scrutiny here. So he had 2 major goals when he set out on his mission to really investigate whether BPA could be performed effectively and safely. The first was to demonstrate a significant improvement in hemodynamics. One of the criticisms of Feinstein's work is that there wasn't enough hemodynamic benefit to justify the complication rate. And he wanted to show that that was just a starting point that better hemodynamics could be achieved. And the second, of course, is to reduce the number of serious complications. To better address hemodynamic improvements, he did a few things. The first is that he performed IVUS guidance on most of these interventions so that he was using appropriately sized balloons, essentially big enough balloons. He would go back on repeated lesions and sometimes re-intervene on them. And he might do this 2, 3, 4 times as needed. And he would bring patients back to the cath lab with the goal of getting their mean PA pressures under 30 millimeters mercury. Wasn't always achievable, but that was his goal. And that led to more interventions per patient, about 4, not 2. And ultimately, it led to a lot more lesions intervened than Feinstein, almost double. For risk reduction, and this probably couldn't really be accomplished if one was going to attempt this in the US, he really paid a lot of attention towards risk reduction. It's somewhat unbelievable, actually, the extent that he went to. Patients were admitted 5 days prior to their procedure and started on an epoprostenol drip. They underwent a right heart catheterization, and those with a cardiac index of less than 2.2 were started on empiric low-dose dobutamine. And that's how they sat for 5 days. They were brought for their procedure. Oxygen saturations were monitored, as in every procedure, but he was careful to pay attention to any even more modest dips in oxygen saturation. If oximetry dipped by more than 4%, the procedure was concluded early. And then post-procedure, all patients were sent to an ICU setting on BiPAP with a swan in place for at least 24 hours. They were started on methylprednisolone for 3 days, and over those 3 days, epoprostenol and dobutamine were weaned. So for every patient undergoing a BPA, they spent 8 days in the hospital on an average of 4 different times. Fortunately, can you imagine if it wasn't a very successful study? That's a tremendous effort, but it was successful. And he followed these patients for a few years before he even published his findings. And he saw really substantial drops in mean PA pressure from the mid-40s to the low 20s on average, improvements in cardiac index and pulmonary vascular resistance. Every patient he performed this on was WHO functional class 3 or 4, and every single patient was class 2 or 1 on 2-year follow-up. His complications, he reported 1 death about 30 days after one of the procedures. This was in a high-risk patient who was dobutamine dependent prior to the procedure. He reported a fair amount of vascular injury. He also called this reperfusion injury at the time. We now know it to be more vascular injury. About 1 in 5 had hemoptysis. Despite that, only less than 2% require mechanical ventilation with endotracheal tube. And then pulmonary artery perforation occurred about 2.5% of the time, which is actually a little bit low compared to subsequent studies, 2 of which required coil embolization. So when you compare Matsubara's results from Feinstein's results, it's pretty easy to see that he achieved his goals. His change in mean PA pressures and pulmonary vascular resistance were outstanding, and his complication rate was less than half. And on the basis of this study, BPA became more well accepted in certain communities, and first it spread across Japan, and Japan has been a leader in this and supplying us with a ton of data. And Europe was a fairly early adopter, and the US lagged behind, still concerned about the initial results of Feinstein's group, but eventually it couldn't be denied that this was an effective procedure for a patient population that really needed one. And the results are reproducible. Here's a recent meta-analysis looking at a wide variety of groups, largely in Japan and across Europe, and their results. Everyone's seeing improvements in mean PA pressure, in PVR, and in cardiac index. Everyone's seeing improvement in New York Heart Association class. Usually patients improve by at least 1 class, and in 6-minute walk distances. And then what's interesting here too, because it's a little bit, if you compare this to, say, another population of congenital heart disease where you see a lot of right ventricular dysfunction due to outflow tract obstruction, you fix the outflow tract obstruction, you may or may not get an improvement in RV function. But BPA is a world unto itself, and a lot of patients present with RV dysfunction, and most patients have normalization of their RV function, and that's been shown on several MRI-based studies. If you look at the complications over time and what large registries are reporting, you see a fair amount of complications reported, just over a third. Things like lung injury, hemoptysis, and vessel injury are relatively common. And that's how many groups have been reporting their complications. I will contend that I think this is somewhat of a disservice in how we report our complications. Lung injury is often picked up radiographically, not from a clinical need. Patients getting chest x-rays afterwards. Hemoptysis, highly common, but it doesn't lead to mechanical ventilation and often doesn't lead to cessation early of a procedure early. Vessel injury, wire perforation, dissection, these things heal. It doesn't necessarily lead to a PA occlusion. They're not necessarily meaningful to a patient who needs to hear about how these complications might affect them. You take the same population of patients and you say, what is the risk of, throughout one's course of BPAs, what's personal risk of a meaningful complication? The risk of endotracheal intubation in this group was less than 6%. PA coil occlusion of less than 2%, and ECMO and death, which of course aren't mutually exclusive, were 3 and 4%. It's not low risk, but it's different than a 1/3 chance of having a bad complication. So again, to summarize, BPA is associated with substantially improved hemodynamic and functional results. It's still a higher risk procedure, as is surgery, but it's becoming a first-line therapy for non-operative patients. And everyone's a little bit touchy about saying it is a first-line therapy, which it is. It's becoming. I'll grant people that, but it really is. And patients are being outsourced if they're not performing it themselves to centers that are doing it. And as we learn more about BPA and it's becoming more popular, we're getting more data, and it's getting interesting. Matsubara again led the world in helping to characterize disease, and he did so angiographically. In 2016, in a second landmark paper, he came out with his experience performing over 500 procedures, and he went through every single angiogram and characterized over 1,900 lesions treated. And what he was able to do is group them into different morphologic classifications based on their angiography. And it went like this: ring lesions. Ring lesions are your classic luminal irregularity. It's the easiest for the eye to pick up. We're used to seeing these in coronary artery disease. There's web lesions, which are somewhat specific to this disease process. It's harder to really appreciate how hard it is to appreciate on a still image. You might see some linear hypodensities somewhere within the vessel. You might see a little bit of haziness, although sharp borders of the vessel, maybe a little bit of under-opacification. You might not really see anything. You may really have to look at the briskness of flow. These are challenging to see and among the most common lesions. Why do they look like that? Well, it goes back to the histology of this. A lot of neo-revascularization of these highly obstructive lesions. You have subtotal occlusions where you can see the distal vessel, but you don't see continuity with the parent vessel. And then you have total occlusions, which speak for themselves. They are stump occlusions where you see nothing beyond them. And then he described this fifth category, tortuous lesions. And I'll talk a little bit more about this. We don't really believe this to be a true thromboembolic obstruction. He went on to characterize the success rate and complication rate of tackling each of these lesions. The ring and web lesions had a very high success rate and a relatively low complication rate. subtotal lesions had a pretty high success rate and a substantially higher complication rate. CTOs, however, had a threefold complication rate, but only a 50% success rate. He was having challenges opening those up. And then the tortuous lesions had a low success rate and a very high complication rate. And since then, people really don't intervene on these tortuous lesions. What they probably are is the secondary effect of CTEPH, which is the pulmonary vasculopathy. They're really probably not. Now, I should mention that he defines success by getting a wire across the lesion and delivering a balloon. That's it. But that was even challenging in those tortuous lesions, probably because they were just really abnormal vasculature. He also described the proportions at which he found or intervened on each lesion. And it suggests that CTOs were relatively uncommon at 3.5%, but it's not true. And he described that this was only the proportions of lesions that he intervened on. So he may have seen more, and we don't know what proportion CTOs are made of, but one can imagine if he had a higher complication rate and he wasn't that successful, he may have decided to intervene elsewhere, spend his time elsewhere, especially because a lot of this initial work was in demonstrating safety of the procedure, less so efficacy of certain higher risk lesions. And one might reasonably question whether or not it makes sense to intervene on CTOs if the complication rate is higher and the success rate is lower. And it probably depends on where they are, right? If you're out in the periphery, opening up the CTO of a subsegmental branch probably doesn't earn you that much in terms of reperfusion. At the segmental level, though, you start to see more substantial hemodynamic effects, and certainly at the lobar level, you're going to recruit substantial amount of vasculature. However, the concern for increased complications had really led to practice patterns that moved away from intervening at higher risk lesions. And most people didn't publish their results, though. It's kind of well known that these were avoided lesions, and some people did. This is one such publication of a group out of Poland. And it was their experience starting their BPA program. 56 patients and 157 BPA sessions. After their first 50 BPA interventions, they had a pretty high complication rate. And they sat down in a group and said, how do we improve our outcomes? So they decided to exclude intervening on all subtotal and total occlusions. And they saw a really dramatic improvement in their complication rate, and shown at the bottom in hemoptysis, vessel injury, and even 14-day mortality. So it was essentially, the evidence was mounting that perhaps we shouldn't be touching these lesions. Around 2021, we started to get data suggesting that maybe we should be focusing on these lesions. And this comes out of a group in Vienna led by Irene Lang, who's another pioneer in this. She had been doing this for a while, and this was a little bit of a shell shock for those who have been doing this and really avoiding these lesions. And people would make excuses like, well, you probably don't get that much benefit anyway from intervening on CTOs, which makes no sense, of course. These are the most obstructive lesions, but we all tell ourselves things so that we can feel okay, ignoring various disease states. And she showed otherwise, and it's a hard thing to show, and she was able to show it because she had 120 patients and over 700 BPA procedures and over 2,500 lesions intervened upon, and she went after everything as best she could. And she, again, grouped lesions in terms of classification that Matsubara had, and described these lesions, put them into two lump groups. The obstructive non-occlusive lesions, which were the ring and web lesions, which comprised the majority, about 70% of total lesions, and the occlusive lesions, either subtotal or total occlusions. And then she went further to subdivide subtotal and total occlusive lesions. So maybe about 15% of each, certainly more than 3.5%. And what she showed was a few things. The first was that the number of successfully treated lesions were predictors of better hemodynamics. That's not a hard step to take, but she was the first to actually show it in her results. The second, and this is big, the impact on relative change in PA pressures was higher for successfully treating an occlusive lesion, either a sub or total chronic occlusion, versus a non-occlusive lesion. And that's what's shown right here, shifted farther to the left. To help support these claims, she looked at the impact on relative change in mean PA pressures for patients who had a successfully treated CTO. So in the left-hand column, it's no CTO. In the middle column, it's one CTO. And then she even looked at those who have more than one CTO successfully intervened on. The relative change in mean PA pressures and PVR kept going up, while the complication percent and specifically pulmonary injury remained flat. She wasn't seeing greater complications in this group, and it's possible that as things evolved, we were just getting better at doing this and avoiding some of the pitfalls that were creating vascular injury. So lesion type did not predict the occurrence of pulmonary injury. However, she also found these very challenging lesions to treat, and her success rate was still only 50%. But places more importance on perhaps tackling these. Now, while she was amassing and putting together her publication of a major body of work, I'll get to that in a minute. Why are CTOs so challenging? Probably multiple reasons, but four big ones. First is that the lesions are hard to cross. You need to get across them, and that requires specialized tools and knowledge of these tools. Second is you can't see what's on the other side of them. The third is you need to be prepared to manage complications. And you have to figure out what those complications might be if no one's really doing them. And no one's really describing what these complications are. They're just describing the percentage. Dr. Lang didn't describe that either. And the fourth is that you need to work within your environment. You're not doing this on one's own. There's variable referral patterns. You have to make sure that the people who are sending you patients are supportive of your efforts. And you need to work within the institution and their level of risk tolerance. So a number of reasons why people and places have not undertaken this feat. Let's talk about crossing the lesion. Knowledge of CTO equipment is really key here. They make stiffer wires. You get a lot more availability of microcatheters and various things to help support your efforts in punching through very challenging disease. Something I'll also mention is backup, catheter backup. For the non-interventionalists in the room and out there, what backup means, it's one ability to push something through a catheter and actually have that force be transmitted forwards. What will happen is if you don't have a catheter that's locked into place, the catheter will push back. Pushing a wire forward will only result in more of the catheter pushing back. We handle this in the coronary arteries by buttressing these catheters against the back wall of the aorta, and even that can be challenging, but we have a relatively reliable diameter vessel with which to work in. In the PAs, you're all over the place, all different sizes and shapes, and we're using coronary gear exclusively to do this. But we don't have the same sort of backup. So crossing the lesion is a challenge. The second is distal visualization. This is a challenge that's not seen in the coronary world. In the coronary world, you need to have collateralization. Here's an example of that. You have a chronically occluded mid and distal RCA, but you have collaterals arising off the left coronary system. And in high-level CTO operators, you have two catheters, and you can see where you're going, or at least where you need to go. And people don't do this unless they have collaterals, because there's no living myocardium. It's not going to survive without these collaterals, so there's no point in attempting it. So you almost always have some sort of visualization, but you don't get that in the lungs. You see nothing beyond them. It's rare to see any kind of collateralization and almost impossible to predict where it might come from. But almost never do you see collateralization. But the lung tissue survives. It's a dual blood supply. It's really just an obstructive lesion leading to pulmonary hypertension for the majority of the patients. And you need to traverse potentially long distances, this same vessel now revascularized, before you get to your target where you can see this branching distal arborization. So that's a challenge. You got to manage complications. You got to know where you are. You got to find out where you are. And I spent a long time figuring out where I was and how to avoid getting there, or at least how not to do damage. Here's a microcatheter, something that slides over a wire. And I'm injecting through that microcatheter to see if my wire is in the correct position. In none of these pictures it's going to be in the correct position. I'll just tell you that. That's the alveoli. This is the bronchi. It looks like a vascular pattern, but it's an airspace. This is out of the lung altogether. You can see the contrast collecting in the fissure. All of these patients did great, by the way. All of them, because I didn't put a balloon across there. And these are obstructive lesions. But you have to figure that out. And you have to make sure you know where you are. And then don't put a balloon across there, or you're going to be dealing with a complication. These patients were none the wiser. In 2021, as Dr. Lang was putting together her massive body of experience, I put together a small series really looking at tackling CTOs. And I did it because I was in the right lab. I trained in CTO interventions as an interventional fellow, though I do not do CTO interventions in the coronaries in practice. We have a robust CTO lab. We have all the equipment. And I was seeing a lot of them. And in some patients, all I was seeing was CTOs. So I had to decide whether or not I was going to help them or not. And as a group, we decided to undertake these. And I published the very early experience in 2021 after about a year and a half, where I tackled every CTO I encountered. It was 15 CTOs. And I was successful at opening 13 of these 15. It took 21 procedures, though. In some cases, I had to go back several times before I was successful. So I had about a 62% success rate per attempt, but an 87% success rate per lesion. So I think that's progress, although small numbers. And if you look at per success attempt, it's still not that much better than either Dr. Lang's or Dr. Matsubara's. They don't describe how many attempts they made, though. They may have made multiple with a 50% success rate. Clinically relevant complications, one patient. What was the complication? They had enough hemoptysis that I was able to treat in the lab that I decided to terminate the procedure early. So they had to come back for another procedure. It was essentially a not very effective procedure. They left the next day per routine. I've been continuing this work. I have not yet had an updated publication on it, but here are my results so far. 49 CTOs intervened on over 60 procedures. Now a nearest 80% success per attempt and 96% success per lesion. This is a learnable skill. We need to figure them out. There are some rules that follow coronary CTO interventions and some rules that are different. We just need to know the rules. Complication rates are very low. If you look at total complications, and depending on what you choose to call a complication, vessel perforation is very common. You go through a complete obstruction, you don't know where you are at the other end. But patients tolerate this very well. Like I said, if you don't put a balloon up and follow it, they don't bleed, they don't cough, they don't even know. Clinically relevant complications, still quite low. 2 patients now have had early procedural termination because of a perforation. None have required coil occlusion of these PAs. And in fact, that's really not very common at all. The more experience one has, the more you realize these will just seal up on their own. And that's best because you can go back and reintervene and open these vessels at a later date. No mechanical ventilation, no deaths in this patient cohort. And there's still lower numbers than Matsubara and a far cry from what Lang reported. But the success rate is much higher than what was previously reported. These need to be learned techniques and something to focus on. Among the other things our group is focusing on, and we're doing so hopefully with the help of your group, with Huey and Sandeep is to look at patients and how they do overall and why some patients don't respond well. And I say we do this in collaboration. You need a lot of numbers to figure this out. Here's our early experience, 26 patients that went through BPA and completed it. We're seeing good PA pressure improvements. We're seeing improvements in cardiac index and a drop in PVR and an increase in pulmonary vascular compliance like every group is. But if you look at these patients on an individual level, and there's a lot of different ways to do it. I did it by PVR here just to illustrate a point and to give a rough overview of the issue I'm talking about. You're going to see patients who respond really well, patients who respond modestly, and patients who didn't respond at all. I chose to use this as a drop in PVR of greater than 2 as a really major response. Probably really should be as a percentage of the whole. But just to give you an understanding, about 40% of patients have a really good response in our initial group. About 30% had a fairly tepid response. And about 30% really had no response at all. However, if you look at the cohort as a whole, people felt better. Nearly 60% were NYHA class 3 and 4 when we started, and 100% were NYHA class 1 and 2. People feel better. How do we explain this? Well, it could be that all of the non-responders were NYHA class 1 and 2 at baseline. That's reasonable. These were lower risk patients. These were patients with better hemodynamics to begin with. There might be a placebo effect. That's certainly possible. Resting right heart catheterization may tell an incomplete story, and that is certainly the case for patients that have lower, or rather more improved hemodynamics, but have substantial symptoms. Poor recruitment during exercise. This is an open research conversation of patients with PVR under 4 and whether or not BPA should even be performed for them. Pulmonary vascular resistance may also not be the best metric to measure success, and some have posited that pulmonary vascular compliance is the better of all the metrics and shows the most robust change as you increase revascularization. But even looking at the hemodynamics, I think, is probably missing a little bit of the point as well. For those of us who are actually doing the procedures, you see when people respond and see when people don't, even before you're measuring the hemodynamics. Here's an example of such. Here's a CTO. I pointed it out with an arrow because what you really need to look at is that double density here. Another of the issues working within the pulmonary vasculature is there's so much overlap. I do this under biplane most of the time, but you can see that double density. This is a large anterior branch supplying 2 of the segments of the lower lobe. I went ahead and intervened upon that, and this is the results immediately. That's 2 segments. Look at those segments in comparison to the more posterior and patent segments of the first panel. They're smaller, they're fairly atretic, they've got reasonable arborization distally, but they don't look like full segments. Well, a week later, they really start to plump up. They already are looking better. This is the norm. This is what you see most of the time. You open up these atretic segments, and over time, they start to remodel. They're filling up with blood. In 3 months, it will look even better. This is another patient with a CTO. This one in the right upper lobe. Stump occlusion. This one I get into. I'm in the lumen. I've opened up into the peripheral vasculature, also atretic. Bring this patient back a week later and it's shut down. This is not the norm, but you see it enough that you wonder, what are the differences in these 2 patients, and can one predict response? We don't have an answer yet. There's no answer. And I think it's going to take large databases where we can really comb through large number of patients to find commonalities between them. And I think that's where the next decade is heading for us, rather than a bunch of publications showing that, yes, I too can lower hemodynamics with this, and yes, it really does work. I'm the 300th person to publish on this. I think we need to look deeper and figure out the following. We need to refine and standardize techniques for intervention so that we improve our success rate and we reduce our complication rate. And we have to do this by publishing papers on technique and going through why we're having complications and how they can be managed. We need to improve pre-procedural imaging, and I didn't touch upon that at all today. That's a topic of its own. But it's a challenge to know what you're walking into in the lab before, despite CT, despite digital subtraction, pulmonary angiography, VQ. You just don't know till you get in there. And then we need to identify and characterize non-responders. And with partners like Huey and Sandeep, where we can start to coalesce our results, and others across the country, I think we're going to have a better shot. I want to thank you all for your attention today. I've shown 2 images of my city, the postcard version and the one we all actually live. Thank you.
Phenomenal job, Zach. And I want to just bring home one of the points that you brought up during your discussion, which is that I think many of you already know in a cardiology community that University of Washington is really a leader in multiple levels, whether it's percutaneous mechanical support and alternative access for that, complex coronary interventions and CTO interventions, and then of course adult congenital heart interventions and pediatric congenital interventions. So to that point, I think you and I have had a lot of conversations about how you are in an environment that really breeds innovation because of the level of risk tolerance. Can you help us to think about where the other areas when it comes to CTEF and CTEF interventions where that becomes really critical for where you are as far as your environment of innovation and risk tolerance versus other places that are just starting?
Yeah, it's a complex question and probably a complex answer too, as you and I have chatted about a while. I think when you're undertaking anything, you need a bailout strategy. So first and foremost, you need your group together. You need to talk about what happens if and or what. And it helps to talk about other groups doing this too. As you have, we also went to other groups who have been doing this. We found out what they were doing, what happens if there's an injury. But it doesn't mean we followed their practice patterns. I think everything at the end of the day goes back to what one brings to the table initially. For example, you and I both have a background in congenital interventions, and one of the rudimentary procedures we perform are occlusions of vessels. A lot of the people who are doing this, who are coronary operators, that's not really in their purview. You're not used to occluding a coronary artery, certainly rarely. But if you are used to the technology at the very least in the various types of occlusions, you potentially can take more risks with the knowledge that you will be able to bail yourself out. So I think that helps. It helps, as I mentioned, to have the equipment available and to have additional expertise around. I had the benefit of one of my CTO mentors in another lab. I was using somewhat advanced CTO techniques initially. I've abandoned most of them because they're not needed, but it was a tremendously helpful resource. But not everyone, the goal here isn't for everyone to pioneer the same thing. It's to learn, okay, now it's doable. What is the real risk and what is the technique so that it spreads, so that we're not only performing CTOs in labs that perform high-risk interventions, unless they truly are high risk. And in fact, it's my belief that they really aren't. You can get yourself into trouble. Like I said, you put a balloon where you shouldn't, you're going to get yourself into trouble, but there's very predictable ways of avoiding that. And so that's been some of my goal, is to get that information out there, to write technical papers on how to do this safely, so that every institution, feels comfortable doing this. That's some of my thoughts.
Thank you, Zach. Fascinating talk. So, like you said, everything probably boils down to sort of patient selection, because I think you really have to figure out who benefits. And from your talk, it's obvious that the PVR benefit, or even some of the symptomatic benefit, does accrue from CTO interventions, and which is what we always are worried about intervening. So it's almost it's a paradox. These are the patients who have the highest complication rate, yet these are the guys who benefit the most. Because that is something that we've seen in our experience, that when you intervene upon these sort of lower risk patients whose PVR is like 3 to 4, 3 to 5, who are reasonably well managed with medical therapy, 3-6 months down the line, the benefit is hard to really perceive. Yes, you may be able to take them off of one medication. So I think, like you said, we need to really kind of build a program towards CTO interventions, because that's where the benefit is.
I think it can be, it's an excellent point, and I think that point can be broadened to so much of what we do. TAVR, for example. We can do TAVR in low-risk patients, and we're going to get excellent results. But the highest-risk patients have the highest mortality from their disease. You're going to have a higher complication rate with this group. But the alternative is so much worse. You just have to decide how you're going to parse this out. I tell my patients who are higher risk, I say there's a higher risk for you, but there's a higher benefit as well. You have worse disease, you can only stand to get substantially better, and the disease will take them, but the risk is present. And that's an individual choice. I don't make that choice for them. I lay out their options. There's another way to approach these patients too, and that is as we start to build data, and we really don't know the full efficacy for all different subtypes, you get surgical level disease of patients who are inoperable, where the whole lower lobe is out. And a lot of places will turn these patients down, CTOs of the entire massive portions of lung, or really ill patients. And you can approach it that way, or you can approach it, if we don't really know who's going to benefit yet, why should we deny this to anybody until we figure that out? And I think that's another way to go. And I think we're finding that, again, these sickest patients, they do well. They do better than nothing, that's for sure. And again, in BPA, it's a little bit different than it has been in some of the other major debates in transcatheter therapies over the years. PCI versus CABG, SAVR versus TAVR. We don't have that debate in this space. And we're talking about non-operable patients, so they don't really have another option.
Thank you. And do you have a PVR cutoff in terms of the higher ones? Like, we know, at least in PTE literature, that, anything greater than 1,000, you don't, you have significant residual pH due to small vessel disease. Do you have a cutoff for your BPA?
No, I have no cutoff. I have no anatomic cutoff, nothing. I will attempt, because I will go in there, and if I don't think I'm going to have a good result or a safe result, I will just be done. So I have that ability, whereas the surgeon certainly doesn't. No one's on bypass when I'm there. I don't intubate anybody. What I do is have, and I don't have a specific cutoff that I can quote to you, but on my higher risk patients, I have anesthesia present. I still give moderate sedation. I still put them on low level of oxygen because I want to see if they desat early. I don't want that to be masked. But I also don't want a cough reflex blunted, which could tell me I'm in the wrong space. So I will have anesthesia present in my higher risk patients. All of our patients are on pulmonary vasodilators, and that's been shown to lower PA pressures in these patients. And as you point out, we certainly have seen that the lower the PA pressures when you're entering a procedure, the lower risks. So we optimize, but we don't do a cutoff.
And then any invasive, are you using invasive CPET to make the decision in terms of whom to even, intervene on, especially, you get your share of obese, 70-year-old patients who are...
Yeah. We haven't been, I think that's probably especially important for CTED, not CTEPH, where you don't see pulmonary hypertension. We don't intervene on CTED in asymptomatic patients. We don't usually find it unless they're being scanned repeatedly post-PE. But for symptomatic patients, even NYHA class 2, we look at their thrombotic burden and just make a decision of whether or not it's in this patient's long-term interest to have it open up. Now, those are lower risk patients to begin with, and we've been more aggressive in saying, no obstruction is better than some obstruction, even if it's not yet led to pulmonary hypertension, because patients are symptomatic. But it is an open research question. The group out of Michigan is trying to recruit other centers to get in there for people with a PVR of less than 4, randomized to pulmonary vasodilators or BPA and reassess at 6 months and see results. And I think that's a good study. But in terms of the multiple comorbid risk factors, we tend to look at disease burden and hemodynamics to help be a guide. And oftentimes we'll still offer people an intervention, but with more caution that this may not be their overriding problem, but we don't know.
Thank you.
Thanks. That was a great talk. What are your thoughts on BPA as an adjunct to pulmonary thromboendarterectomy?
You mean intentionally, like, so there's been two major conversations. One is you do PTE, you rescan, you do repeat hemodynamics. If they're not normalized, you go find the disease and you hit it. The other is you intentionally leave one side of the lung alone because the disease is more distal and you do the other. I think both seem very reasonable. I don't particularly feel strongly on needless interventions. If patients are doing well and their hemodynamics are very good post-PTE, I think you're done. You can always offer BPA down the line, but I wouldn't put people through the ringer on that. But for residual disease, meaningful residual disease, I personally think we should be aggressive about that. I think this is a disease that gets worse over time. Even if the obstruction doesn't worsen, a high PVR can lead to pulmonary vascular remodeling, and especially in younger patients. If it's a younger patient where you have decades worth of life to live, they may have deleterious effects from that. We haven't done a ton of this at my institution. I haven't seen a ton of residual disease, at least not coming back to me, so I don't have personal experience.
Thank you, Dr. Steinberg. Just a question. Have there been internationally any studies about like drug-coated balloons and BPA, or like is that something maybe to reduce recurrence because we intervene on the same lesion sometimes multiple times?
Not to my knowledge. And people have asked me about stenting too. So the interesting thing is this disease doesn't really come back. This is really a very effective strategy. The reinterventions on lesions are not because there's been restenosis, but rather, as I showed you in that one angiogram, you get a maturation of the vessels. And so as you're dilating up proximal disease, you may be underestimating the full capacity of that vessel to accept blood. And if you go back in, especially in CTOs, and especially in large territory, if you go back in a week or a month later, and oftentimes you are, this is one of several procedures that patients are undergoing, these are durable results. If it stays open, it stays open. But you may have undersized your balloon initially. And so that's where reintervention has been important. I don't think anyone has reported this neointimal hyperproliferation or advancement of the media like you do like you see in the coronaries. It's different physiology there. So I don't know that balloon-coated or drug-coated balloons are the future necessarily, and although initially when I got into this, I said, how could you not stent all this stuff? That would be a disaster. You don't want stents in these areas.
So I think there's low pressure circulation, right? Not high pressure plumbing.
But that's a great feature of this, is that you do it, you do not have to come back and deal with it again unless they throw more clot. And that's pretty well documented at this point.
And another technical question, like let's say you perfed and you have your wire outside in a bronchial space or alveolar space. Advancing a microcatheter is still reasonably safe compared to inflating a balloon there.
Yeah, that's a good question because in the coronaries you don't do that. And in the coronaries you don't need to because you can see where the distal vessel is, or you have to use wire. It is safe. And that's a difference between, I think, the disease state in the coronaries and perhaps the makeup of the vessel wall, but especially when you're going through. See, this may be why subtotal occlusions have worse complication rates, because there was always blood that could pass to some degree through these lesions, but not in CTOs. And the disease is spongy, and it can really recoil back into its shape if you don't crush it off to the side, for better or worse. And in this case, I think it's a benefit because it will really just close up around there. And again, it's also a fairly low-pressure system, and so because of that, you really don't need to do much of anything. Every so often, you need to proximally occlude with a balloon for something like that, but it's rare. You really don't. If you put a balloon up across that, you're going to need to proximally occlude. You're going to get a bleed. But most of those seal up within 5 minutes with or without heparin reversal.
And one last question. From a financial perspective for the institutions and the physicians, like developing this program in a new place, how does that work?
You mean how much do we make the institution versus how much does it cost?
Or, yeah, the cost for the hospital versus, like, is it beneficial for a new program to get built or no? I mean, it's just more practical.
So I work in an environment, one of the benefits is I don't fully know, although there is a lot of chatter in the community of how to maximize the work we're doing, right? Because you're doing multiple interventions and how do you bill for it? I will say that recently, there was a discussion amongst a number of us about how to optimize billing, and a few people have really optimized it. You can bill for additional BPA. You can bill for every single balloon that goes up. You can only bill for up to 2 pulmonary angiograms. You can bill for a right heart cath. I think institutions are making a good deal of money. Also, most patients are going home after observation over a day, and almost routinely, despite what Feinstein showed, if patients aren't developing issues in the lab, I have not seen them ever develop after. If they develop in the lab, they might worsen after. That's different. But if there's no issue in the lab, patients are doing fine, so there's additional discussion as a same-day procedure. The issue there is anticoagulation management. You want to keep people on anticoagulation as much as possible, but reduce bleeding risk post-procedure. So that's still being worked out. The other thing is, whenever you're bringing a new therapy, is what does it cost for equipment? This coronary equipment. You have it all on the shelves. So I think the relative cost for an institution, especially after the initial period where we did, and I imagine you guys are doing the same, is everyone went to the ICU. We downgraded that after the first year, and it's been 4 more years of really smooth sailing on a step-down unit run by advanced practitioners. So I think it makes a good deal of sense cost-wise. That's my sense.
Thank you.
And then I guess I want to also make this mention about cost. I hit ALARA 5 months out of the last 12 months since Dr. Steinberg visited us and started our BPA program. So there is a personal cost. But anyway, I want to thank you, Dr. Steinberg, for an amazing, amazing talk, as well as the incredible innovation that you're doing for our field and really pushing it forward. Thank you.